Aortic dissection is a critical, life-threatening condition where a tear occurs in the intima of the aorta. This allows blood to surge through the tear, creating a false lumen or second channel between the layers of the aortic wall. Clinicians primarily use two systems to categorize dissections, which dictates the urgency and type of intervention required. Stanford classification. Type A involves the ascending aorta. This is a surgical emergency due to the risk of aortic rupture, coronary artery occlusion, or acute aortic regurgitation. Type B involves only the descending aorta, distal to the left subclavian artery. These are often managed medically unless complications arise. DBACI classification. Type 1 originates in the ascending aorta, involves aortic arch and descending aorta. Type 2 originates in and is limited to the ascending aorta. Type 3 begins in the descending aorta and extends distally above diaphragm in type 3A or below the diaphragm in type 3B. The primary driver is often a combination of high wall tension and a weakened arterial media. Hypertension is the most significant risk factor, present in 70 to 80% of cases. Genetic connective tissue disorders like Marfan syndrome, Ehlers-Danlos syndrome, and Ley-Deeds syndrome are also likely to cause aortic dissection. Congenital anomalies like bicuspid aortic valve or coarctation of aorta can be associated with aortic dissection. Inflammatory conditions like giant cell arteritis, iatrogenic during cardiac catheterization, or blunt trauma like a car accident. The classic presentation is often described as sudden excruciating pain, tearing or ripping sensation. Location is anterior chest pain in type A or interscapular back pain in type B. Neurological deficits, stroke symptoms or paraplegia if branch vessels are occluded, either carotids or spinal arteries. Pulse deficits, significant difference in blood pressure between arms or absent pulses in the lower extremities. New diastolic murmur indicative of acute aortic regurgitation. Time is the most critical factor in diagnosis of aortic dissection. CT angiography is the gold standard for stable patients due to high sensitivity and specificity. It clearly visualizes the intimal flap and the extent of the dissection. Transesophageal echocardiography is preferred for unstable patients or in the operating room. It is excellent for